Oddly enough, it has been now 50 years since Charles Daughter first took a look inside and did a femoropopliteal lesion and then published about it. Now we have a lot more options, not necessarily a lot of great compliance and agreement on what exactly we should be doing. But that's why there is a paper coming up in JACC that I think you really should know about. It's the end treatment of femoropopliteal lesions. So many options, little consensus, and I am with the author of this particular editorial comment. This is Dr. Mehdi Shishehbor, who is the Director of Endovascular Services at the Cleveland Clinic, the Heart and Vascular Institute there. You're talking about the IN.PACT SFA study, which was presented a while back. Now they have a new analysis. Remind us at the top about IN.PACT SFA.
Yeah, so IN.PACT SFA is a study to evaluate the utility, safety, and efficacy of drug-coated balloon in the femoropopliteal lesions, as you mentioned, compared to balloon angioplasty alone, something that's been around for over 50 years, as you mentioned. And basically, the study looks at, obviously, the efficacy of this device in regards to patency, up to 12 months. That was published previously, and the FDA has given this device an indication based on that data. And the paper that's coming out now is looking at the 24 months. Obviously, when we treat these kind of segments in the leg, we are interested in long-term patency. So there's a lot of enthusiasm and waiting to try to get this result out there so folks can see the patency of these devices in the long term, 2 years.
Now, this was approved with 12 months worth of data, if I remember right, and we should mention there is a second drug-coated balloon that has been approved, correct?
Yes. There are currently 2 drug-coated balloons that are available in the United States for clinical use. One of them is the IN.PACT. The other one is offered by BARD, and both devices are available for clinical use. The 24 months data for BARD has been presented, but has not been published yet.
So here in JACC, we're going to take a look at the 24-month data for the IN.PACT SFA. What did they find?
Well, it was interesting, actually, to my own surprise, and as you said, we wrote the editorial on it. I thought the patency was comparable to studies with the stents. And as you know, stents provide this scaffold that supports keeping the artery open.
Right.
Whereas balloons typically have this limitation that after you dilate the plaque and you push it to the side, you have these dissections and these recoils. So in general, the feeling has been that over long term, the patency of these devices, even with the drug coating, will not be as good. So they showed that they had 78% or so patency at 24 months with minimal really complications and little stent use in the setting of using these balloons. There are some issues, obviously. The trial design is that the balloon angioplasty is performed first. If the results are decent, meaning that there is no major dissection, then the DCB was used. So there's a little bit of a patient selection there.
It's not an all-comers trial.
It's not really an all-comers trial. So it's really after balloon angioplasty. So perform angioplasty. If you have a good result, if there's no major dissection, then the patients were randomized. But still, I think a 78% patency at 24 months gives us some insurance and assurance that the patency with this technology is decent and could potentially be an alternative to a stenting in patients with lower extremity PAD.
And this kind of concurs with, goes along with a trial, or it was a registry, I think, over in Europe.
Yes.
So we now have at least some data that suggests that they're on the right track. Now the question is, so who would you use this in?
So, there's always the challenge. It's complicated. That's a very complicated question. So, obviously, this is designed to be used in patients with PAD, folks with claudication, or even folks that may have rest pain. In patients with ulcers or gangrene, it has not really been studied that well. I think physicians are using them for those patients too. I think that the technology will most likely, at least in my hand, I will be using it after angioplasty. If the results with angioplasty are decent, meaning that there is no major dissection, then I would be probably using this technology, especially in shorter lesions less than 20 centimeter, which are the ones that have been studied in the trials so far. The registry you mentioned is actually very supportive in a sense that that's more real world. As you know, know,
Exactly.
in the trial setting, you know, we're kind of selective as to who we study, but in a registry, it's all comers. So it gives us a better sense, even though it has its own limitations, as to who we can select for this kind of a technology.
So there are cases where you might not want to use a stent, and this approach might give you a first option before you end up stenting down the line?
Absolutely. I mean, you know, one of the issues with the stents is that eventually they close. So every time I see a patient, I always tell them that it's not a lifetime warranty. Just because we're putting a stent in there is not going to last you forever. And the issue is that when those stents form scars and they reocclude and patients come back, is a challenge. You know, crossing those lesions are challenging, and then treating them is also challenging. So there are a lot of physicians that have been waiting for this kind of technology, and they like to take this no stent or minimal stent approach, meaning that give treat the lesion, introduce the drug to the vessel, and then if you need to, maybe spot stent in the areas that are really necessary, or don't stent at all. And if we can get data and results up to 2, 3, 4 years that are comparable with the stents, then I think that the motivation to put the stents will go down significantly, I believe.
I mean, your editorial comment puts it, so many options, so little consensus. Yeah. But we are seeing fewer limbs being removed, fewer amputations. So we're figuring it out, but it just, how much longer is it going to be before we get some consensus?
Well, that's the beauty of medicine, is a philosophy. And, you know, as a physician, I think many of us enjoy that, enjoy the fact that this is there's not a cookbook approach to this, right, and that there are, options available. Every patient is different, and each therapy should be tailored to the patient and their presentation and their clinical characteristics. Obviously, we want to have data. We want to have head-to-head data between two devices that are supposed to do similar things, so we know which one to use. Also, especially in the femoropopliteal lesions, as you mentioned in that editorial, there are so many options. Even with the stents, you know, we have drug-eluting stents, we have interwoven stents, we have regular stents, and now with the DCBs, and then there are other modalities that we can use as adjunct. So I think that, again, at the end, it comes down to the patient, what they present with, tailoring, personalizing your approach to the patient, and then using your own judgment with the available data to select the best therapy for that patient.
Now, this is IN.PACT SFA. It's being presented here in San Francisco at TCT. And if you're looking at this, that means that the embargo has passed, so you can go online at JACC and read the paper itself and the editorial comment that we've been talking about. And for Cardio Source World News Interventions, I'm Executive Editor Rick McGuire.